So ovarian reserve is defined as the number of oocytes or in other words, oocyte quantity in the ovary at any given time. So this should be differentiated from oocyte quality, which is the potential of a fertilized oocyte to result in a live-born infant. So why is the ovarian reserve need to be tested? So any reserve which depletes need to be checked or tested, as ovarian reserve depletes and it may deplete very rapidly in some women, and this ovarian reserve cannot be replenished by any means. So ovarian reserve testing becomes important. So these are risk factors for diminished ovarian reserve, like advanced age of more than 35 years, women with family history of early menopause, with some genetic conditions, or with conditions like endometriosis which cause ovarian injury, and women with history of ovarian surgery or a history of gonadotoxic therapy or pelvic irradiation and history of smoking. So these women will be at risk for diminished ovarian reserve and should be tested for the same. So what are the ovarian reserve tests which are available? So first and foremost is the chronological age. So as you all know, as the age increases, as a woman ages, the ovarian reserve decreases. So we have the maximum ovarian reserve at 18 to 22 weeks of post-conception, that is in the fetal life. Then at birth it decreases, and after birth it depletes, and then at after 35 years of age, it depletes rapidly, and after 40 to 50 years, in between 40 to 50 years, this will be the end of fertility and fertility and menopause sets in. So in some women, as though they start with the normal reserve because of some environmental conditions or some as mentioned, endometriosis or a history of chemotherapy, the ovarian reserve may deplete rapidly and they may end up in diminished ovarian reserve. Some women may have a low reserve to start with, as in this curve, these women have the low reserve to start with, but normal depletion, but the end product is reduced diminished ovarian reserve and early menopause. So coming to the biochemical measures of ovarian reserve, what are these biochemical measures? These are the hormones which are secreted from the oocytes, like primordial follicles, primary, secondary, antral follicles. These are the hormones which are secreted from the follicular pool and the pituitary, which we assess to assess the ovarian reserve of a woman. So when this follicular pool is reduced, that is the primordial, primary, preantral and early antral follicles are reduced, the AMH and inhibin B levels which are secreted from the follicular pool are reduced, and as a result there is a negative impact on the central negative feedback. As a result, FSH is raised. So this AMH and inhibin B can be used as a direct measures for reduced as the levels decreases, we may direct measures of the ovarian reserve, whereas increased FSH, because of the reduced AMH and inhibin negative feedback is reduced, FSH is increased, which can be used to assess ovarian reserve. So as the FSH is increased, there will be early onset of follicular growth and increased basal E2 levels. So there will be a shortened cycle. These can be used as an indirect measures for decreased ovarian reserve. So coming to the details of biochemical measures, FSH to be measured on day 2 or day 3 of the cycle, but there is a variation between cycles. This has high specificity but low sensitivity, which means high values indicates the decreased ovarian reserve, but very early stages of diminished ovarian reserve cannot be detected. Basal serum E2 levels alone may not be useful, but with the serum FSH levels, as you can see here, basal E2 levels more than 70 with the normal FSH on day 2 should not be misinterpreted as a normal ovarian reserve, as a high basal E2 levels masks the increased FSH levels and may reduce the FSH levels to the normal levels. So AMH is a very important hormone. This is secreted by the granulosa cells of the recruited follicles until they become sensitive to FSH. So AMH plays an important role in the maintenance of follicle pool. So normal range is taken as 2 to 6.8 nanogram per ml. Advantages are gonadotrophin independent, cycle day independent. It is relatively constant between cycles, more sensitive than FSH and tends to decline before FSH rises. So the other dynamic tests, these are not used nowadays. And then biophysical markers, ovarian volume, lack of sensitivity, but the mean ovarian volume less than 3 ml or a low mean diameter of less than 2 centimeters predicts poor ovarian response. So antral follicle count. So antral follicle count is the sum of the number of follicles, antral follicles in both ovaries gives the AFC. 2 to 10 mm mean diameter follicles in the greatest 2D plane at early follicular phase is measured. So this has low intercycle variability. Normal considered as 10 to 18, whereas less than 7 indicates poor response. So what do the studies say about ovarian reserve testing? So currently AMH and AFC are most sensitive and reliable markers of ovarian reserve. Combined ovarian reserve tests do not consistently improve predictive ability over that of a single ovarian reserve test. So selecting a marker of ovarian reserve, AMH, AFC, FSH. So obviously AMH is more sensitive than FSH, tends to decline before FSH rises. AFC and AMH have been shown to be equivalent in most of the studies. But most of the times, in more than 30% of population, we may find AFC and AMH to be discordant. There will be discrepancy in AFC and AMH. That means AMH in few women, AMH may be high, but the AFC on the scan shows as less AFC. So what to be given importance, AFC or AMH? So when seen physiological point of view, if you see, the AMH is secreted from the resting pool of the follicles, that is before they are recruited, primordial, primary and very early antral follicles, whereas AFC or the antral follicles, these are a recruitable pool which are sensitive to FSH. So both should be seen as a different entities. So if a woman comes with the very less AMH but the AFC are good, so it means that the resting pool, that is the actual reserve, is decreasing. So we have to use the AFC as soon as possible. We have to use the follicle as soon as possible. Whereas when a woman comes with a less AFC, her AMH is good, then intercycle variability of AFC should be considered. And then in some cases, the technical aspects, technical variations should also be considered. So I will conclude with this important slide. AMH and AFC are currently simplest, most sensitive and specific measures of ovarian reserve. Markers of ovarian reserve shown to be good predictors of oocyte yield, but poor independent predictors of reproductive potential. They should not be used as a fertility test or to deny access to infertility treatment. Age is the best marker for oocyte quality. Ovarian reserve testing allows pre-treatment patient counseling, individualization of stimulation strategy, increased cost effectiveness, and enhanced safety. Thank you.